Good morning. Today I will be presenting a case on monogenic diabetes, more specifically Walcott-Rallison syndrome. This syndrome has less than 60 cases throughout the world. So this is a case that I will be discussing about a female baby who was 5 months old, was referred by the pediatrician to the diabetes center. The patient had been admitted with the pediatrician just before the referral for 10 days with diabetic ketoacidosis. On admission to the pediatrician, the random blood sugar was 850 mg/% and HbA1c was 12.5. The patient was treated for the above with insulin, stabilized, discharged, and then referred to the diabetes center. So as the baby was only 5 months old, monogenic diabetes was suspected and a history of consanguineous marriage in the parents was also reported. It was a second degree consanguinity of first cousins. The parents and the baby were called back in 3 days with glucometer readings for dose adjustments and also to collect blood sample for genetic testing, which we would send later on to Hattersley lab, which is in Exeter. Sorry. The blood was collected from the baby and from both the parents as well and was shipped to Exeter, UK at Dr. Andrew Hattersley's lab. In the meanwhile, insulin dose adjustments were continued. Reports were awaited and this was the report of the girl. So it was a homozygous expression of the EIF2AK3 gene, which basically encodes for the PERK protein. It stands for PKA endoplasmic reticulum kinase. This is responsible for the integrity of the cell membrane. So this had a mutation. It was a frame shift mutation in this gene. We also had the reports of both the parents. Both the parents had heterozygous mutations in the same gene. So what are the features of this particular syndrome? Firstly, there's neonatal or early onset diabetes, usually presents before 6 months of age. But there have been cases where one or two of the cases have been presented at 2.5 years of age. Then there's multiple epiphyseal dysplasia, mainly affecting the long bones. Hepatic dysfunction is due to elevated hepatic enzymes, hepatomegaly, and recurrent acute liver failure. So these are the classical symptoms of this syndrome, but less frequently and inconsistently, there are certain more that are expressed. That is, firstly, impaired renal function, global dysfunction of pancreas, hypertrophy of pancreas, intellectual deficit and developmental delay with neuromotor deficit and microcephaly, epilepsy, recurrent episodes of multi-organ failure. These multi-organ failures basically manifest after a flu-like syndrome. So basically any minor illness can lead to a sudden multi-organ failure in this patient. So the parents have to be advised to hospitalize the child even with minor flu-like symptoms. Neutropenia associated with recurrent infections. So what is the ideal treatment for this syndrome? Basically, ideally there must be close therapeutic monitoring because of frequent episodes of hypoglycemia with any treatment and ketoacidosis. For this, the insulin pump is recommended. There must not be a very tight control of blood sugar because insulin, as the episodes of hypoglycemia are extremely common in these cases. And the parents or caretakers must be educated about the occurrence of multi-organ failure and how to report them it on time based on the symptoms. Bone fractures are very common and must be treated at orthopedic level. But the treatment given to this case because of low socioeconomic status of the family and illiteracy is, as the baby's feeding schedule was erratic, injection insulatard basal insulin was given twice daily. Glucometer readings were taken 2 to 3 times daily and were advised, and insulin doses adjusted from time to time telephonically and with clinical visits. Due to poor financial status and literacy level, follow-up was not up to the mark. The baby is now 2.5 years old. This was diagnosed when she was 5 months old. After a gap of about 1.5 years, a clinical visit was done because the mother was pregnant again and the possibility for a prenatal genetic testing was explored. The parents are not economically well-to-do, so they are not treating the child well. They are not. They are skipping most of their insulin doses. They basically don't want the child to survive, and they have come for the visit for a prenatal genetic testing, and we are in the method of trying to find a chorionic villus to send it for a DNA biopsy right now. In the meantime, as the baby was 2 years old, other tests were undertaken, keeping in mind the other features of Walcott-Rallison syndrome. These were pancreatic hypoplasia. So there is a slight chance a suboptimally visualized pancreas which appears slightly hypoplastic. Suggested CT scan abdomen for confirmation. If clinically implicated, the parents could not afford the CT scan and weren't willing to do so. So we could not do a CT scan for the child. Epiphyseal dysplasia. So there is suspicious platyspondyle of cervical vertebrae, dysplastic epiphysis of visualized long bones, and these findings may represent multiple epiphyseal dysplasia, which is a clinical feature of Walcott-Rallison syndrome. So these were a few of the blood tests and liver function tests that was done, and if we can see, the SGPT and the serum alkaline phosphatase has been increased in this particular case. So the prognosis is poor and patient usually dies at a young age. Mostly the survival rate is 4 years, but there have been 2 cases out of the 60 cases that were reported in the world of the child, of the person living up to 35 years of age, out of which 1 case had no liver dysfunction till the age of 32. The main cause of death are usually multi-organ failure with hepatic and renal dysfunction and encephalopathy. Half of the cases, so 60 cases were reported. Most of the cases are not reported because of early death and unavailability of the tests in particular areas, which are done in Exeter. So there are probably more cases than this, but it is mainly limited to areas of Turkey, Pakistan, Middle East, where the consanguinity is very common. So we are still following up the child. There haven't been many episodes of flu-like syndrome, so but there is a lot of pain, fractures of the child, and we are still following up the case. Thank you.
I think very good case presentation and very interesting case. As far as the questions, I don't have any because I have never seen such a case myself.
No, we haven't. We haven't.
So,
we did check for the antibodies, but because it was within 5 months of age, we did not suspect type 1.
See, there's juvenile, the diabetes of occurring at neonatal diabetes are the one which are because of KIR 6.2 mutations,
transient and
permanent varieties, and they respond to oral drugs.
KIR is very mild. You know, it is not 850 and decay.
They were all
there is a
tested
recurrent
actually.
decay.
There is a syndrome called DEND syndrome. And these DEND syndromes are the one who have got the sulfur receptor in the brain also. So therefore, once you give the child, they cannot walk. The milestones are also impaired.
So the ABCC, the KCN, yeah, and the INS all were tested.
Yeah, that
Only
is
this
a
one
common gene which is affected in the permanent variety. As Sir was saying, the temporary and the permanent variety, the KCNJ11 is the most commonly affected.
Yes.
And these are the patients who have good C-peptide.
Yes.
And they have only problems of potassium closure channel. Channel is not closed.
There's a very low dose of sulfonylurea and they respond. They are the one who stay on sulfonylurea lifelong. They don't require insulin.
Wondering whether that was done in this
One
one.
case in our hospital.
No, KIR we have seen, but not this.
We don't know. This we haven't seen.
Fantastic work.
From
Very good
audience
work.
if you have.
Anybody has any experience of neonatal diabetes, less than 6 months old? Is it type 1 diabetes? Can occur type 1 at this age?
No.
No. Not in the audience.
Typical type.
That's okay. So it's a good case.
Thank you.
Wonderful case.
Thank you. I think with this we come to end of this session, and we had some real wonderful.
One more is coming? She's not come, that's why I asked you. Uploading the PPT, okay.